All right, welcome everybody to the Victorian Trauma Grand Round. It's the Royal Melbourne Hospital Emergency Department's turn to host this particular one. Before we start, I'd like to acknowledge the country from which we're broadcasting today, which is Wurundjeri land of the people of the Kulin Nation. But we are broadcasting, I hope, to people from many First Nations lands across Australia, Aotearoa and many other parts of the world. In fact, before we say that, we would also pay respects to elders past, present and emerging, and hopefully to some who are here in the room or with us online. We have people from, I believe, 17 countries, as well as every state of Australia, and over 1,000 people registered, which is fantastic. We're going to be talking about traumatic cardiac arrest here, and I think the really important thing to bear in mind is not just about traumatic cardiac arrest, but it's about those moments that lead up to traumatic cardiac arrest, because it's the same interventions that are really important for peri-arrest and arrest, and the sooner you treat these things, the less chance you have of actually progressing to arrest, and you can get your patient home again. Please note we're recording this. It'll be available again on vtgr.org, but obviously don't do anything too silly unless you want it recorded for posterity. We have a Slido arrangement. You've probably been emailed this. But if not, take a quick photo of the screen so you can log in and send questions and poll and so forth, if that's your thing. All right, here's our program. It's a very tight program. We're going to try and squeeze in as many things as we can into the 2 hours available, because that's how we like to do things in the emergency department. Opening things up will be Dr. David Camilleri. David's one of our emergency physicians here. He started out his career in Malta. He went to Cairns. He ended up here, and now he works between us at the Royal Melbourne ED and Life Flight in Queensland. He particularly is interested in team dynamics and how people work together. He's going to introduce the topic and take us through his version of traumatic cardiac arrest. Take it away, David.
Thanks, everyone. So, traumatic cardiac arrest. I'm going to be talking about the aims as to why we do and we have a guideline for traumatic cardiac arrest at the Royal Melbourne. We're going to talk about the controversies, and we're also going to talk about the priorities when we get these patients. I like to get us all thinking about a case, because I think it will get us a bit of a framework of where we go from here. So we've got a 42-year-old male coming in. This is a shot from one of our trauma rooms, what we write on our glass partitions where patients are coming in. And as you can see, we have a severe blunt trauma, and the patient looks like they're in severe shock. It's a bit difficult to tell, however, what's causing the shock at the moment, right? Are they bleeding out? Do they have chest injuries with those low SATs? Is that GCS because they're shocked, or is it because there's head injuries as well? We don't know. And personally, if I look at this case and get told this is coming in, I'd be a bit apprehensive about the patient. I'd probably be a bit scared about team leading this. And so we all know that when we're a bit scared, we can't think properly, and having an approach about how we're going to deal with patients like this actually helps us, right? And so as an ED, we started thinking about how do we come up with an approach. And specifically, a bunch of us were at a conference in 2016 overseas, and we had the luck of listening to Professor Jason Smith talk about traumatic cardiac arrest. And that got a team of us coming back thinking about this. We also looked at the NSCORE guideline 11.10.1, which talks about the management of cardiac arrest, which also came out the same year as this paper, 2016. And personally, I had a bit of experience with LifeFlight, who had already had an SOP, or a standard operating procedure, about traumatic cardiac arrest. And we looked at the Sydney HAMS one as well. The basic premise was, A, that unlike what I taught when I was a junior reg, traumatic cardiac arrest is not an exercise in futility. And B, I think the core thing is that traumatic arrest patients are in a low flow state compared to medical arrest patients who might have a normal flow state. And this started us thinking away a bit from the CABC approach and looking at it in another way. If we go back to basics, medical cardiac arrest patients are basically split into the 4 H's and the 4 T's, right? We keep it simple for us because, again, we know it's a difficult situation where we're dealing with these patients. However, when one thinks of the traumatic cardiac arrest from a physiological approach, things are a bit actually simpler. and hence maybe the approach had to be reviewed. Traumatic arrest is actually dependent on 2 H's and 2 T's, so hypoxia, hypovolemia, tension pneumothorax, and tamponade. And this can be further simplified into 3 processes: hypoxia, hypovolemia, and obstruction. So hypoxic shock, hypovolemic shock, obstructive shock. The former, hypoxic shock, leads to reduced cardiac output because there's no oxygen reaching the heart. And the last 2 are actually due to no preload reaching the heart. Now, it's important to think about these causes. Hypovolemia is cited in papers, military and civilian data, as being 66% of these cardiac arrests. So hemorrhage is 66% of the cause of these patients being in peri-arrest, as Mark mentioned, and moving on to arrest. So that's really the bulk of our work. Then we talk about, this is more military data, about the obstructive bit, where tension pneumothorax is about 33% and cardiac tamponade is 10%. And hypoxia is 7%, again from military data. However, there's some more recent data coming from the Netherlands HEM service, which suggests that maybe hypoxia is a bit higher than that. And I do know that all those percentages add up to more than 100%. Don't forget that some patients can have 1 or 2 processes happening at the same time. Now, what about the controversies? CPR. If you think about the physiology again, you've got either no oxygen, or you've got, as the most likely cause, no preload, so the heart is actually empty. Pumping on the chest of someone who's got an empty heart is not going to make anything better. It's probably potentially going to cause more injuries if there are rib fractures, if there are lung injuries, and so CPR becomes a secondary priority. Excuse me. From the adrenaline point of view, things are a bit more murky in the sense that some papers suggest that it aids in outcomes and helps in ROSC and discharge out of hospital, whilst others suggest that it actually makes things worse. We, as a hospital, decided to align with the ANSCO guideline, which also says that adrenaline is a secondary priority. We do, however, use adrenaline if we have ROSC, and we find, for example, that the heart has cardiomyopathy going on, or if we think that there is vasodilation going from other causes. Maybe they've also got neurogenic shock going on at the same time. So the guideline itself. I'm showing you the latest and greatest. This is this year's version, which has increased a few things in there. And primarily it's because we are an obstetric trauma center, and so we've decided to add another column to our approach because we want to also make sure that we involve our obstetric colleagues when we need them. I think it's the most important line for me in here is the fact that we're trying to perform things simultaneously and not sequentially. So we're trying to do all these things at the same time. And this is obviously easy in our center where we get a lot of people coming down to help us, but it might be more difficult in other centers and smaller centers, and it might be difficult for our pre-hospital colleagues watching us tonight. In which case, I think it's very important for our colleagues to stay within their scope of practice. And if any procedures are beyond your scope of practice, do not feel at fault for not doing all this, and you shouldn't be faulted for not doing all of this either, because you have stayed within your scope of practice. The priority, I think, if you don't have a big enough team, is probably to look at hemorrhage first, because as we said, is the most likely cause, and then focus on the other causes, starting with the thing that you think is most likely causing the traumatic arrest in your patient. We start off with the setup. We want our patients to have arrested less than 10 minutes, either in the department they've arrested with us or they've arrested in the last 10 minutes before they've arrived. And this is because the outcomes beyond 10 minutes are known to be dismal. We activate a trauma call and we get our massive exsanguination pack, and we'll talk about that in a bit later. And being a trauma center, an obstetric trauma center, we also get our obstetric colleagues to come across if we have a pregnant trauma more than 20 weeks. And we also get our neonatal response team coming from the Royal Women's as well. But also notice that we consider medical causes. And if we think that there is a medical cause, we go down the usual ALS guideline. And this has happened a few times. This is the nuts and bolts of the guideline. This is where sort of most of the stuff that we're going to be talking about tonight is about. We are going to have speakers talking about all of these columns except breeding. Breeding was covered by Prof. Fitzgerald in a VTGR earlier this year, and we don't really have much to add to his talk. So we're going to be talking about the other 4. But we're also going to be talking about team leadership, and we're also going to be talking about what happens when it comes to decision making. You know, we might achieve ROSC, we might not achieve ROSC, when do we stop? And we also need to talk about what happens to us as clinicians in these cases. There's a lot of moral injury potentially, there's a lot of ethical discussions happening in these cases, so we need to talk about the hot debrief as well. I'm now going to show you a video we prepared for you guys to see sort of a bit how this actually happens in real life. And hopefully this works. There we go.
This is a traumatic cardiac arrest team. Don't start CPR yet. Let's reverse reversible causes. Catastrophic hemorrhage. Is there bleeding?
Yes, I've got bleeding at the leg here. I'm putting a tourniquet on.
So tourniquet's on.
He's got a pelvic binder on. It looks like it's tight in the right spot. I've got RV access. I'm going to start doing some blades.
First unit red cells commenced.
Alex, airway.
Yeah, airway's paper. Not going to prepare to intubate.
Okay, you're preparing to intubate. Jonathan, David, can I get bilateral finger thoracostomy?
Yeah.
Decompress the chest. Can you let me know when you've done that? Amali, can you check the pump?
Yep.
Amen.
Chest decompress.
Chest decompress, chest decompress.
I'm checking for tamponade and cardiac activity.
I'm going to put in a MAC line just to get bigger access, okay?
Thank you, David.
Okay, I'm just drawing some blood out of the MAC line. I'm getting bloods for a VBG, ROTEM, and trauma bloods. And since we've started a MEP, we're going to give some TXA and some calcium.
Emma, we've had 2 units of packed red blood cells. Would you like FFP or platelets next?
Emma, I'm ready to intubate. Scott, if you can maintain inline stabilisation, the tube is going in. You can pass the tube over. Just bougie out.
Okay, team, let's recap. We've stopped catastrophic hemorrhage. We've got a tourniquet and a binder on. Alex should be intubated. We've done bilateral chest decompression. We're giving blood. All reversible causes are reversed. There's no tamponade on ultrasound. Let's start CPR and focus on giving blood products.
Alright, time for rhythm check. Yep. Continue compressions, David. Oxygen always. All others clear. Charging the defib. Alright, hands off. Playing ready rhythm and echo. Yep. Alright, ready non-shockable rhythm. Disarming defib. Recommence CPR.
Emma, there's no cardiac activity now.
No cardiac activity. Thank you, Amali.
And this is one of the topics we'll be talking about later, so decision about cessation of treatment or whether you have ROSC. Thank you, everyone. These are some of the references for you all.
All right, that's fantastic, David. Apologies to all our people watching from home if you're having trouble with the stream. I think we're having some difficulties with our Wi-Fi. I trust that we're recording this, so we'll be able to share it with you later on. Next up is Dr. Emma West, emergency physician, Director of Emergency Medicine Training, or one of our Directors of Emergency Medicine Training here at the Royal Melbourne. 25 years experience in emergency medicine. She will be talking about leading the team, which is something we put a lot of effort into teaching our registrars to do here at the Melbourne.
Good evening, everyone. I'm delighted to be here to speak with you all. Please indulge me for a moment. Imagine it's you and I in your place of work, but in your emergency department, and I have a message for you. Hi, I'm Emma. I'd like you to see the next patient. It's a 42-year-old man, pedestrian versus car, with head, chest, abdo and pelvic injuries and an open lower leg fracture. He's got a blood pressure of 60, a heart rate of 130, a low GCS, low SATs, a pelvic binder, 1 times IV access. He'll be here in 5 to 10 minutes, so sort that out for me, please. I'm off for a cup of tea. How does it feel knowing that you're about to assemble and lead a team of people trying to keep this man alive? In all likelihood, the people who arrive to care for this man won't know each other, they won't know each other's names, and they bring together an unknown level of skill and expertise, all in the name of caring for this man. And you want them working at their absolute best. So it would be natural to feel a sense of cognitive overload and heightened emotions. Team leadership is about the work that you've already done, the time and effort that you've invested in training. You know the fundamental ingredient for a successful high-performance resuscitation team is training. So invest in multidisciplinary and interprofessional relationships. Train together and train regularly. Get everyone involved. Nurses, doctors, teams from anaesthetics, trauma, ED, the ward clerks, the orderlies, and iron out all the kinks that you find so that you can provide excellence in care every time. Set up your simulation room so it reflects your trauma resuscitation room, or even better, conduct in situ sims. Do it regularly so you can learn from recent cases. There's always something to learn. But most importantly, learn from each other. Share the fundamentals of successful teamwork. So because you train, you feel calm. So back to our patient. You send out a well-oiled notification process in your site. At Royal Melbourne Hospital, it will be a trauma call, and that will assemble a team of anaesthetics, a trauma surgeon and their trauma team, an ED physician and their team, specialist nurses, a blood clinician, CT goes on hold, theatre goes on hold, blood bank is ready. A ward clerk will meet the trauma at the door, register them and ensure smooth transition into the department. Trauma care is unpredictable, but we set up our trauma room in a predictable way with predictable equipment. Bilateral finger thoracostomy equipment, specialist airway equipment, a massive exsanguination pack, a pelvic binder, a thoracotomy tray. And everyone's familiar with them because we train together, as you do. And now your team begin to arrive. You stand at the door and welcome them. You as team leader put a sticker on your chest that identifies you as team leader with your name on it. You appear calm, confident and likeable because they're the essential ingredients of bringing a team together. They'll want to help you. Then you move on to role allocation. You welcome people, you give them the role, you give them their name. It's much better to communicate with someone when you know their name. For example, if I say, Alex, how's it going with your airway assessment? It's much more meaningful than, hey, guy up the end, the tall one, what are you doing up there? So make sure everyone's named. Be specific when you allocate them a task. Tell them how difficult it will be, what you're expecting, what you'll need them to do, and ensure that they're confident and competent today in their emotional state of being able to do that task. Have an eye to noise control and crowd control and use the clinical red line. So only those with labels and names enter the trauma resuscitation zone and the others can stand outside and observe quietly if needed. And now comes the all-important brief. This is where you gather your team around and let your team know what you're worried about, how concerned you are, what are the likely interventions, and what's the worst case scenario. For example, team, we have a critically unwell 42-year-old man with severe shock. He'll need hemorrhage control, bilateral chest decompression, intubation and large bore vascular access so we can give blood. I'm really worried he may have a traumatic arrest. Show humility, your team will want to help you. And then the pre-hospital team arrives. You meet and greet them. You identify any immediate life threats, for example, has the patient arrested? You transfer and begin assessment and interventions, and your team do that because they know how to do it. They train together. While you receive the brief I missed handover. Your team perform well. They're calm. They use accurate and closed loop communication. Jonathan, can you insert the chest, can you perform a finger thoracostomy on the left-hand side? Yes, Emma, I'm performing a finger thoracostomy on the left. You share your mental model. Your team are aware they can speak up for patient safety, and you know to respond to their graded assertiveness. The resuscitation phase is where you summarise the primary survey, you make a synthesis of what you're finding, you set tasks to your team in order of priority, and you supervise that it's done, and then you repeat it. So congratulations team, you've resuscitated the patient. Now from me to you, just 5 tips that I think about when I'm team leader. First of all, where are we headed? Never lose sight of the big picture. What is definitive care? So are they going to the operative theatre, interventional radiology or both? Or have they stabilised enough to first go to CT and then that decision's being made? But be aware, delay in decision making is put your patient at risk. So advocate for a decision to be made even if you don't know what that decision is. Use a rehearsed mental model. We use it for critical procedures like front of neck access, and equally, it's just as important for performance as a team leader. Run through how you will brief someone, how you'll update your team, what are the phrases you'll use. It will support you for better performance each time that you run a trauma. Dealing with disruptive team members. Just remember, they're doing it because often there's inexperience, they're uncomfortable in a foreign environment, or they don't have all the information. So your job is to help them. Work within their skill set and take them from disruptive to task-focused. Set them a task that they can do. Or help them reframe their concerns, and if you have to, ask them to pop out and get an update from a second in charge outside the room. But never aggravate them, like I'd never aggravate my 2-year-old Rory. Your job is to have a positive workspace and a clear, calm environment so everybody can work at their best. Provide rationales for the decisions and the interventions that you make. So for example, if I say, quiet please, the team may not listen. But if I say, quiet please, I need to hear the results of the primary survey, it motivates and focuses the team. They also listen to the primary survey. Equally, if you're applying a pelvic binder, you should say, because we have an open book pelvis and I'm really worried about hemorrhage. People will get on and do it straight away. Finally, empower your team. Allow them to make a synthesis of their assessment and suggest things like, I think we need a left-hand sided finger thoracostomy for our tension pneumothorax. To which I'll say, let's do a left-hand sided finger thoracostomy for the tension pneumothorax. And beware of being given something like an arterial blood gas with 20 points of information that when you're trying to keep someone alive, you can't analyse. Pass it off to someone, a support person behind you that can analyse the information and feed it back to you. For example, they might actually see the CO2 is high in a critically head-injured patient. It's very difficult to do that on the spot. So mostly this is all about being able to feel like you've done the most you can for the critically unwell patient. There's a lot of trauma involved in trauma care in terms of well-being. So if we can train together and feel like we're doing a good job, then we're doing the best that we can. Thank you very much.
Fantastic, Emma. All right, who have we got next? Scott Willard, clinical nurse educator from the Royal Melbourne ED, has been teaching and training nurses and doctors here for a long time. He's a lead of the ED Trauma Special Interest Group, actively involved in multidisciplinary trauma team training, and in fact all of our resuscitation team training at the Royal Melbourne, and one of our go-to people for getting education messages out to our team. He is going to be talking to us tonight about the blood clinician role and how we use that to make trauma care safer at the Royal Melbourne. Take it away, Scott.
Thanks, Mark. So today we're going to talk all things hemorrhage control, vascular access. We're going to elaborate on what David has talked about in terms of our massive exsanguination pack, or our MEP. We're going to talk about the role of the blood clinician in this coordinated trauma response. We're going to touch briefly on consideration of tranexamic acid and calcium administration in mass transfusion events. And we're going to talk about the role of ROTEM as well in these events. So as David mentioned previously, uncontrolled hemorrhage is associated with, or that is associated with traumatic injuries, one of the leading causes of preventable death amongst injured patients. So we're going to take a bit of time just to discuss the components of trauma resuscitation, including control of bleeding, and the hemostatic resuscitation. So it probably comes as no surprise that when we talk about hemorrhage control, the overall aim is to stop the bleeding. So in the setting of traumatic cardiac arrest, the identification and control of life-threatening hemorrhage is paramount so that intravascular volume can be restored via blood transfusion. So you can see in the table that we've got here, there are a variety of options that can be utilised in the emergency department to temporarily control bleeding, to enable resuscitation, and to bridge to more definitive hemorrhage control. Manual pressure, as outlined here, is the basis for controlling all surgical bleeding. The ability to occlude a bleeding source is reliant on the effective application of pressure. Can it be pinched between fingers, or can it be compressed against something firm? And of course, the size of the area of the hemorrhage that you're trying to provide manual pressure to. Tourniquets are indicated for significant extremity hemorrhage, where direct pressure is ineffective or impractical. And then, of course, pelvic binders. So bleeding from pelvic fractures is often multifactorial, arterial, venous, and bony hemorrhage. And therefore, the use of a pelvic binder to reapproximate pelvic alignment is imperative to prevent ongoing bleeding. So when we're considering vascular access, and we've got a MET pack, and we're thinking about giving it to the patient that we've talked about before, consideration of flow rates and appropriate venous access is vital. So the image here outlines the range of different lines that we have available in ED at the Royal Melbourne Hospital and the corresponding flow rates that are associated with each of those lines. The thing that is important here is that we need to take into consideration Pesae's law. So Pesae's law describes the relationship between catheter length, catheter diameter, and fluid viscosity. The key point to consider here is that the best vascular action option might be different based on the environment that you're within, the clinician's skill, and the allocation of resources. So the version of vascular access that we might select in a completely well-resourced trauma resuscitation might be very different to what you would use on road or at a regional centre. And these things will impact insertion time and can potentially delay other important tasks that are critical to resuscitation of these patients. Essentially, the thing that we want you to take out of this is having a look at all of the different options and being mindful of what is applicable and available in your toolbox of vascular access. The other option that we haven't included on this picture is intraosseous access. So it's important to consider that the maximum rate of administration through an IO needle when it's inserted is roughly equivalent to a 21 gauge peripheral cannula, and that is also associated with if there's a pressure bag used as well. It's also important to consider that there are various IO insertion sites, the humerus and the tibia, as well as the sternum. So when we think about different types of insertion sites, the flow rate is higher through the sternum and then the humerus and the tibia. But for us in the setting of a traumatic cardiac arrest, the ideal insertion site is humeral, as it's above the diaphragm and it does take into consideration any potential pelvic fractures. And again, whilst we can see here that the IO flow rate might not be superior to other types of vascular access, it is still potentially an important part of our vascular access algorithm as part of our toolbox. So I want to take a little bit of time to talk about our MET-Pack. So what is contained within our MET-Pack? So a MET-Pack has 4 units of red blood cells, 4 units or 2 bags of fresh frozen plasma, and 4 units or 1 bag of pooled platelets. And you can see the MET-Pack comes in a nice little esky that's sealed on the side. So when all of the contents of that MET-Pack that I've mentioned is transfused, it's the equivalent of a 1:1:1 transfusion ratio. And the contents can be stored for 2 hours before being used or in the transfusion laboratory. So it gives us a little bit of time to get the MEP down before the patient arrives to help prepare. So how do we get it? We make a phone call to Blood Bank requesting the MEP, and the Blood Bank will ask just for some basic patient demographics, so age, gender, and if we know pregnancy status. The decision to order the MEP lies ultimately with the team leader, but they can be aided by the use of either the shock index or the ABC tool. In terms of the benefits and the use of the MEP, so a recent audit of emergency blood use from March 2022 found that throughout the hospital, 84 patients had a MEP requested. 80, or roughly 95% of those were requested by ED, and the remainder were requested by ICU or theatre. 36% of those that were utilised, 9 of them required 2 MEP packs or more, and 62% of those MEPs requested weren't utilised, with over those 2/3 returned to blood bank within an hour. So I suppose the take-home message is just because you've requested a MEP doesn't necessarily mean you have to use it, and it's very easy to return. So now, blood clinician. In terms of the role, so what does the blood clinician do? The recognition and importance of a dedicated resource to manage safe and effective blood administration during a high intensity trauma resuscitation, as Emma mentioned, it's responsible for preparing all of the different types of equipment that we might need to facilitate a mass transfusion. So that includes lines, checking units, keeping track of administration of the MEP, as well as providing prompts regarding complementary medications such as TXA and calcium. And they play an important role in the prevention of coagulopathy, or the triad of death, which obviously comprises of acidosis, hypothermia, and coagulopathy. Their role is also equally important, as Emma mentioned. This is a really stressful environment. We've got the blood out, we're getting ready to give it. So the blood clinician just provides another opportunity to ease the cognitive burden of the team leader by keeping track of those units administered, and by being that resource that if we require additional MEPs, or if we need to send them back, run a ROTEM, anything that's associated with the blood clinician, they can do it without having to burden the team leader. Emma also spoke about allocation of roles within a trauma response, and the allocation of a blood clinician happens in the same way that the allocation of a procedure nurse or an airway clinician would happen. We've got dedicated stickers that go to blood clinicians, and the flowchart that you see up on the screen here is located in all of the trauma and resus rooms off to the side in the space that the blood clinician would stand, just so that they've got an extra resource that's clearly available for them, again, to kind of ease the stress and anxiety of the situation, so that every single application of a MEP pack and transfusion is the same. So calcium and TXA. So TXA has been shown to improve survival rates of patients with or at risk of significant hemorrhage if it's given within the first 3 hours of the injury. It has been mentioned before, but TXA was involved as part of the PATCH study, where eligible patients received a loading dose of 1 gram infused over 10 minutes, and then a further 1 gram via an infusion over 8 hours. And we're all waiting to see the outcome of the PATCH trial. The other thing that we should consider whenever we're considering massive transfusion is that TXA can also be indicated by the ROTEM and the administration of the ROTEM, but we should never wait for the ROTEM results to administer TXA. It should always happen before that if it's indicated. In terms of calcium administration, so we know that ionised calcium plays a critical role in the formation and stabilisation of fibrin. Subsequent acute hypocalcemia has an impact on all platelet-related functions, as well as cardiac-related effects, such as a reduction in cardiac contractility and systemic vascular resistance. So consideration of hypocalcemia in the management of these patients requiring massive transfusion is important, as the presence of the citrate within each pack of packed red blood cells and FFP that acts as a preservative can induce hypocalcemia. And as we saw on the previous slide in that blood clinician flowchart, it's part of the role of the blood clinician to ease that cognitive burden and prompt the team leader clinician as to whether calcium might be required in this case. So, ROTEM. We're very lucky that we have a ROTEM on-site in ED at the Royal Melbourne, just outside of both of the trauma rooms. So the ROTEM allows point-of-care measuring of hemostasis by assessing clot formation, firmness, and fibrinolysis within a 10-minute period. This allows for essentially a more precise transfusion of blood products. And as you might have noticed in our video that David showed before, it's just as simple as taking off another blue top coags tube and having a separate resource step outside and run the ROTEM test for us. Research from both the Royal Adelaide Hospital and a similar study that has been run in Queensland has found that the introduction of a ROTEM leads to target-oriented transfusion with an increased use of cryo and decreased use of FFP. In patients who also received cryo, there was a decrease in the subsequent administration of further blood products, and there was also an associated 25% reduction in the cost of blood products for that hospital. And then the question at the bottom, cryo versus fibrogen concentrate. So the FASTI study highlighted the importance of fibrinogen replacement in severely injured trauma patients with major hemorrhage. Whilst currently there is limited evidence comparing fibrogen concentrate and cryo, RMH is currently involved in the FASTI-2 trial, and we're watching the progress of trials such as CryoStat-2, which will hopefully further inform best practice of how it is best to replace fibrogen in patients presenting with major trauma. And here's a list of references for you.
Brilliant. Thanks very much, Scott. We're running, I think, a little bit ahead of time, which is amazing. Did not expect that to be happening. It gives us a moment to breathe. The great thing about that talk is it really drives home for me the fact that you can't deliver this kind of care to these kind of patients without a lot of prior planning. So you can't just expect an esky full of thawed plasma, fresh red cells and platelets to appear in your ED without having gone through a long period of planning with your blood bank and whoever your supporting haematologists are. We're very fortunate in a big place like this, but it's something you need to work at well ahead of time in order to get it right. Our next speaker is coming to us online, I believe, Dr. Ronnie Kreiser. Ronnie's one of our staff anaesthetists, particularly one of our cardiac anaesthetists, and there he is, he's just appeared. He is well familiar with helping out with our difficult traumatic airways in the emergency department at the Royal Melbourne. He's going to be talking about, of course, peri-arrest trauma intubation. I'll leave it to Ronnie to take over.
Good evening, everyone. I'm sorry I can't be there. I hope for two things. One, that the technology works, and two, that my dogs don't bark. Okay. So the other thing we could actually call this talk is just making oxygen good again, because that's what it's really about, oxygenation. David mentioned that hypoxia accounts for around 7% of peri-arrests in the trauma situation. And I say oxygen as opposed to ventilation, and we'll talk a little bit more about that. So why are trauma airways so difficult? Well, it's multifactorial. There's obviously all the patient issues that are first and foremost. And those difficulties can be obvious to the eye, and sometimes they're hidden beneath the bull neck. It's made more difficult because of the nature of trauma and our requirements to look after the cervical spine and protect the airway. So we can't put them in that classical sniffing the morning air position where we like to intubate people electively. There's foreign matter that can be in the airway. These patients typically are unfasted, so vomit sadly makes up more of my job than I'd like to think about. And then there's the difficulty of pre-oxygenation with combative patients or patients who are peri-arrest. There's the staffing issues. As Emma's video showed earlier on, it's a chaotic scene and there's multiple teams working side by side. So the focus can be scattered around the place, which is why job allocations to specific events is so important. Many of you are working in areas where you may not have such a large team available to you, and the resources may start and stop with you, so you must move around the patient. And then there's a notion of emergent timing where you just don't have the time to get the people you want present as quickly as you can. So many of the pitfalls that we see with the airway can be predictably unpredictable. So always anticipate the difficult airway when it comes to trauma. There's multiple pathologies that can be involved, and these can extend all the way from the mouth with bleeding and teeth, all the way through to the lungs with tension pneumothorax and pulmonary hemorrhage. And then we'll also talk a little bit about drug selection when you're trying to secure the airway. So when it comes to securing the airway, or at least establishing oxygenation, what are your choices? There's the classic four. So there's bag mask ventilation, but this can be really difficult in this sort of situation where airway trauma can make creating a patent airway difficult. Intrathoracic injuries can make bag mask ventilation difficult as well. The positioning of an LMA has its challenges and limitations, both through distortion of airway anatomy, which makes a seal difficult. There's soiling of the airway, and the LMA doesn't necessarily protect the airway from soiling. Doesn't let you suction down beyond the cords. And ventilation can be tricky if you need higher pressures. When it comes to endotracheal intubations, they're the difficulties we've already spoken about. And then finally, the last-ditch effort is front of neck access. Now, this is both cognitive as well as technical challenges. And the use of cognitive aids are really there to help overcome that challenge of making the decision to move to someone's neck. And when it comes to technical challenges, that's what simulation is for and training. Let's have a look at endotracheal tube versus an LMA or a supraglottic airway. When it comes to trauma, endotracheal tube is the gold standard. It's got numerous advantages, prevents soiled airways spilling over down into the lungs. It allows for better ventilation options, including PEEP and achieving higher airway pressures if required, but we'll talk about some of the pitfalls of that. It can be a conduit for intervention such as suctioning, and it's less susceptible to dislodgement in comparison to an LMA. But remember, perfection is the enemy of the good. So if you are not able to intubate, the LMA is still able to oxygenate in many, many scenarios. So endotracheal tube is the gold standard, but coming in at silver is an LMA. So still useful if you need it and you can't intubate. There are many cognitive aids in management of the airway. This is from the Difficult Airway Society of the UK, and it was originally designed for use in more elective spheres. But many of the messages from this are still relevant to the traumatic airway management. And these includes all the skills that spill over. So direct laryngoscopy, use of a supraglottic device, bag mask ventilation, and if necessary, front of neck access. Here's a little question for you. And this might be a little bit confronting for some of my colleagues, so apologies in advance, but I won't really apologize. So what do these things have in common? The President Franklin D. Roosevelt, the release of Citizen Kane, the movie, for some of you young people, that was a movie. A new car used to cost $850, the Macintosh laryngoscope, and the song Chattanooga Choo Choo. Hopefully all of you recognize that these were all invented around 80 years ago. So my challenge to you is, I think we can do better. And we have done better. We've invented the video laryngoscope. And your first attempt at laryngoscopy and intubation in trauma and in theatre and anywhere is your best attempt. It's your best chance of success. So let's look at the facts regarding video laryngoscopy. So it's been proven to increase your first pass success, decrease the risk of esophageal intubations. It reduces the hypoxia associated with intubation. It improves successful intubation in known difficult airways, and trauma would usually fit into that. It reduces airway trauma itself from firm, hard surfaces up against soft mucosas. And by allowing your assistant to see the screen, it allows for better communication during the intubation. So the people next to you can actually assist you because they know what you can and can't see. Now, there are two types of video laryngoscopes. One follows loosely the Macintosh shape, and one has a hyperangulated blade. So the hyperangulated blade, there's multiple ones on the market. It does have a slightly different technique to a usual Macintosh blade. And overall, the Cochrane study, which looked at tens of thousands of intubations, found that the hyperangulated blade did overall perform best. Now, the concept of best is arguable, and I'm open to that argument if you like. The main difference, though, with the hyperangulated blade is it's not designed to flatten the tongue out so you can see from the lips through to the cords, like a Macintosh blade is. It's actually designed to follow the normal curve of the tongue around and then look up at the cords. The beauty of not actually having to flatten the curve of the tongue is you don't put as much force into the mouth. So it's much better for people who you're trying to protect their C-spine. One of the limitations of this is you must use a stylet or a bougie when using this type of device. They are not designed and will not work if you're trying to put a tube in straight away. And last but not least, and this goes for every single medical procedure, you must practice with it. Do not bring it out in anger for the first time. So what about backups? You always have to have your plan A for intubation in trauma, but you've always got to be thinking through the next few stages. So in this photo here, the staff that were involved in this particular trauma actually positioned a 14-gauge cannula in the airway, so they had a conduit for creating a surgical airway if they needed, if intubation was impossible. So always predict the unpredictable. Always know that trauma, by definition, is going to be a difficult intubation. I want to speak briefly just about some specific physiological conditions where airway management spills over into the arrested and the peri-arrest state. And that includes the tamponade physiology and the effect of positive pressure ventilation on it. So let's take it back to basics. Blood flows downhill. When you have a pericardium that's filled with fluid, it basically creates an uphill gradient. Blood won't flow uphill, so your venous return drops off, your cardiac output goes off. If you start positive pressure ventilation in this setting, whatever small amount of venous return that comes through may also be impacted upon by high pressure ventilation. In other words, the gradient of the hill just got that little bit higher. So intubate the patient, oxygenate them, but minimize your airway pressures so you can flatten the curve and help with venous return. Drug selection for the peri-arrest or arrested intubation. Well, you need to look at your patient first. Person who has a GCS of 3 really does not need a hypnotic necessarily. The other thing is look where your lines are and look where you're giving the drugs and whether or not they're actually going to reach the patient. A number of times I've been in arrests where drugs injected have actually come out a wound higher up on the limb. When it comes to hypnotics, less is often more, but the same can't be said for muscle relaxants, where more is more. They take a long time to get around in the peri-arrest situation because venous return is down, cardiac output is down, so circulation time is down. Patients who are GCS3 often have their own muscle relaxant on board simply because the muscles are hypoxic and unable to contract. On the release of tamponade, what you'll find is cardiac output rapidly returns, blood pressure skyrockets, and only then is there a risk of real awareness, and then you may need to introduce a hypnotic in these type of patients to ensure lack of awareness. So, general tips and tricks. Whatever you do, whatever device you choose, just open the airway and oxygenate. Keep it simple, but remember the traps of trauma to the airway, such as penetrating wounds, which will make bag mask ventilation and LMAs almost impossible to use due to the air leaking out the side through the laceration. Always plan for a difficult airway, and a video laryngoscope should always be part of your plan A. Prepare and share with your team what plan B will be, so everyone is on a common pathway. Thanks very much.
That's fantastic, Ronnie. I think we're going to probably need to just skip questions and move on to our next bit, because we're now back on schedule, which is good. We're not going to touch breathing. David might have mentioned already, but because really the pleural spaces was really well handled in the last Alfred Grand Round by Mark Fitzgerald, so you can always go back to vtgr.org and watch that. We're going to move on to the pump. Dr. Amali Lokuge is emergency physician and clinical lead for ultrasound here at the Royal Melbourne ED. She has taught many registrars and consultants how to be excellent ultrasonographers here at Royal Melbourne, and helped us to drive a really good ultrasound program. She's going to talk about checking the pump and other roles of ultrasound in trauma peri-arrest.
Thanks, Mark. So, I'm going to talk to you about how to use ultrasound in the peri-arrest and arrested trauma patient. I think you have a cool role if you're the ultrasound person in that resuscitation room, because you're going to be able to look inside the patient and tell the team leader what interventions are required. So what are we looking for? We're looking to see how the heart's working. Is it contracting? Is it underfilled and we need to control the hemorrhage and push the MEP pack in? Or is there inadequate contraction because this is the end stage of the resuscitation, there's too many insults, like hypoxemia, hypocalcemia? Or is there an underlying cardiomyopathy? Is there a pericardial tamponade and we need to go to resuscitative thoracotomy? Or if there's standstill and we need to think as a team whether we need to stop this resuscitation? Because we're a heterogeneous group of people, I thought I'd concentrate on the abdominal transducer. This is the one that's ubiquitous in IEDs. We're really good at EFAST, we're familiar with it. But this is a cardiac arrest, so if you know how to use the echo transducer, I'd go to that first. It'll give you more chest views, the subxiphoid view will be easier. So back to the abdominal transducer. You want to have your hand above the transducer so you can put continuous downward graded pressure. Go right in the subxiphoid space, just underneath the Xiphi sternum, push into the left subcostal space and look to the left. Have your transducer marker towards the patient's right side and have your depth set at about 15 to 20 centimetres until you find the heart. But once you find the heart, decrease your depth so the heart is in the middle of the screen because that's your focal zone. Once you get your 4-chamber view of the heart, rotate 90 degrees and look towards the liver because this will give you your IVC. So this is the nice view that you want to get. You're imaging through the liver in the subxiphoid space, so you get liver first, then you get the right side of the heart, right ventricle, right atrium, and posterior to that, the left ventricle, left atrium. The posterior pericardium will be nice and bright white. When you turn 90 degrees on that, you should see the IVC opening into the right atrium. But often this is what you get. A bit of liver, bowel gas, reverberation artifact, and dirty shadowing. You can't see the heart, it's obscured. But if you do that downward graded pressure, the bowel gas should move out of the way like a curtain. If you release the pressure, the bowel gas moves back in. But continuous downward pressure, the bowel gas gives up, moves to the side, and you should be able to see a nice heart. But sometimes, free gas, subcutaneous emphysema, this is the only view you get in the subxiphoid space. In that case, you need to move to the chest. You can use the echo transducer or the abdominal transducer. Here I'm using the echo transducer, probe marker to the patient's right shoulder, left parasternal. You go as close to the sternum as possible in the third or the fourth rib space, and then you get your parasternal long axis view. You get that same view if you use the abdominal probe in the same position, probe marker to the right shoulder. It's just flipped around so that the apex is now on the right-hand side of the screen instead of the left-hand side of the screen. It doesn't really matter because what you're looking at is the heart working? Is it contracting? Are there adequate contractions? Is there a pericardial effusion? But if you really want an on-axis image, you can rotate the transducer so it's now, the probe marker is now at the left hip and you should get your on-axis view. So what are we looking for? First of all, hypovolemia. So this is in the peri-arrest patient or the just arrested patient. You're going to see a heart that's working really hard, small cavities. The cavities are almost going to disappear with each systole, and with that you're going to get a small IVC that collapses. Yaganauer did a really lovely study which showed that hypotensive patients who are resuscitated to normal obs, if you looked at their IVCs, the cohort of patients who had an IVC less than 10 millimetres were more likely to develop hypotension later, suggesting that you can monitor resuscitation, the adequacy of it, with the IVC. Similarly, CT studies show that a flat IVC predicts the need for a massive transfusion and increased mortality, especially in the elderly. Then you look to see how the heart's contracting. So on the right-hand side, you've got a heart that's contracting very well. It's contracting in a coordinated fashion, but you can see that despite the contractions, the heart is just not able to generate a pulse or a blood pressure. So this is pseudo-PEA, where you've got asystole, but you can still see contractions on ultrasound. The heart on the left side of the screen is further on from that. There is still coordinated contraction, it's just not so much. The echogenic material in the right side of the heart is called spontaneous echo contrast, and this is where the blood flow is so slow that the ultrasound is able to pick it up. And that's pre-thrombus formation. But it's important to pick up the contractility because a heart that's still contracting is still salvageable. And studies show that in the arrested patient, if there is contractility on ultrasound, these patients are more likely to have ROSC, more likely to survive. And you need to tell your team leader, we need to reverse the insults before we go to asystole. Or you might see this, a dilated cardiomyopathy because of underlying heart disease, and you can tell the team leader that an ALS algorithm is important in this case as well. Then you look for pericardial effusion because these are the patients that do well with resuscitative thoracotomy. So pericardial effusion is typically anterior between the liver and the right side of the heart. This is because of the patients arriving in hospital with a cardiac injury, it's going to be low pressure injuries, right atrial, right ventricular tears. The blood, it is initially anechoic or black, as it is in this case, but as it starts to clot, it becomes echogenic. When there's a pericardial tamponade, your IVC is going to be dilated and non-collapsing. It's important to see the pericardial effusion because studies show that when patients are selected out for resuscitative thoracotomy with a pericardial effusion, they're more likely to have survival than if it's an unselected population. Even in blunt trauma, your rates of survival become close to penetrating trauma when you select out the patients with pericardial effusion. Sometimes the pericardial effusion can be posteriorly, so that's where you need your heart in the middle of the screen. And this is what hematoma looks like, echogenic material within the anechoic space. You can get false positives though, so this is a right pleural effusion. You can see there's anechoic fluid around the heart. Is it pericardial? You want to look between the myocardium and the pericardium to see if there's fluid. And this happens because normally you're ultrasounding lung around the heart, and lung has air in it, it reflects the ultrasound. But when there's fluid, you can see fluid around the heart. You can get around this by looking at the heart through the chest to see if there's a pericardial effusion. But just remember that a left pleural effusion could be a decompressed pericardial effusion, especially with pericardial tears or penetrating trauma. Peritoneal fluid can also look like pericardial fluid. So this is because you're going through the peritoneal space to look at the heart. If in doubt, look through the chest and you'll see that it's actually peritoneal. So here, where all that black space is where the liver would normally sit. And then your imaging as well, if your transducer is angled anteriorly rather than posteriorly, you may see the aorta coming out of the left ventricle. So there you can see that's your left atrium, and it looks like pericardial fluid, but if you change your transducer, you'll see that there's no pericardial fluid. But if in doubt, check your IVC. It should correlate with your heart. Pericardial tamponade, dilated IVC, hypovolemia, small IVC. And then stand still. Is there coordinated contraction or no contraction at all? Because these are the patients that don't do well. The ROSC is unlikely, they're unlikely to survive. And you're looking for coordinated contraction. There can be movement of the valves and a bit of movement of the spontaneous contrast. That's because you're pushing in blood, but the heart shouldn't move. The heart could move with ventilation, but there shouldn't be any contraction of the muscles. And eventually you get thrombus formation. Consider some rare causes, so echogenic material within the right side with a dilated right atrium, right ventricle could be fat emboli, and echogenic clot in the pericardium could also be aortic injury, but this is typically distal to the isthmus, so look at your abdominal aorta. So finally, you want to look at the heart because you want to see, is it a filling issue, is it a contraction issue, is it pericardial effusion and tamponade, or is there standstill? Try and get as many views as you can, and reassess, because with resuscitation and filling, things can change. Pericardial effusions can develop, and when in doubt, check the IVC.
All right, you can all have to watch that on slow motion on the VTGR. That'll take all that in, and hopefully you can get pictures as good as that when you do it. I certainly can't. We're going to get the speakers, the first four speakers, I think, going to come and join us on a panel now. We're just going to have 10 minutes with a chance to do some questions. Who's chairing that one? Andy Buck is going to be chairing this panel. Andy Buck, emergency physician here at the Royal Melbourne, as of recently director of the Emergency Trauma Management course, which I'm sure a lot of you will have done. And we've got everybody else who you already know. I'll leave it to you, Andy.
Great, thanks, Mark. Welcome everyone, and welcome to everyone watching online. We have been bombarded with questions. We won't be able to get to all of them. I'm sorry, we'll try and answer the ones we don't get to on the panel by typing answers to you straight after this. We might just jump into it in the interest of time. So we've had several questions. Dave, I'm going to ping to you first. There's one about, you talked about the evidence and a bit of the process used in guideline development at RMH. And what tips would you have for people at non-major trauma centres who may be looking to set up a traumatic arrest guideline?
I think the most important thing, it was alluded to by Mark as well, it's a team sport. You're going to involve a lot of members from your hospital in the care of these patients. So the same process we went through when we started thinking about setting up our traumatic arrest guideline is involving all those people in those columns of the guideline. So we involved our hematology colleagues, we involved our anesthetic colleagues, we involved our surgical colleagues, our trauma colleagues, and we sat down and we discussed and we broke it down into the evidence and rather sometimes the lack of evidence and what's the best approach to these things. And we work in a hospital that has all those services, and you might be working in a hospital or a service that doesn't have those services, but there will be stakeholders in each of these services that need to be involved. So the people that are involved in the care of these patients or of the surgical patients are the ones that I think need to be involved.
Yeah, great. So really, utilising your whole hospital. It's going to potentially be involved. Everyone in the hospital is going to be involved in the guideline development.
Absolutely.
And bringing everyone with you and looking at what resources you have is really important, isn't it? Because not everyone has the same resources as we do here. Emma, there's a question about handover in the unstable, non-arrested patient. So the patient that's just hitting the bed, when should that happen? And I'm guessing what the person who asked means is pre or post transfer to the bed and the team starting to work, because we know that can be a point of disruption. And how long should it go for?
Great question, actually. We train a lot in and around this, and we've decided to standardise all handover process so that even in the stable trauma, we transfer the patient and begin assessment while receiving the brief IMIST handover, so 45 seconds to a minute. There's often additional information, but that can be given to a second in charge person or given later in the trauma resuscitation process. Now, when the patient's arrested, it may just be that you follow that standard process, transfer across interventions, pause on the IMIST handover while things are being done. For example, if you've got no pulse, you really need to announce to your team, you've got a traumatic cardiac arrest here, start the interventions that were planned for. And then at some point, you could even get a second in charge to take the IMIST handover and correct you if you're in error anywhere. But really, it's about being able to make those timely interventions when, sometimes they're very close to arrest and they just need to happen immediately. And so I think everybody's on the same page. We all want to work together for the best of the patient, and we understand that we can sometimes just wait.
Yeah, and something I've learnt from Emma since starting at the Royal Melbourne, it's just consistency is important with that, I think, particularly with your pre-hospital service in your area. Try and get everyone doing it the same. So when your paramedics are coming in, they know what to expect and they know what's going to happen. No matter how sick the patient is, they're going to get a consistent response and the handover is going to happen the same way. It's really important. Thanks, Emma. Amali, there's a question about ultrasound. Not all of us are as slick at it as you are. Some of us are really not that good. And there's a question about, and also the fact it can be a bit of a time lag and a bit of a time waste, so particularly in this arrest situation where people can just go, hang on, I'm just going to get one more view. Do you have any advice for the non-experts like me and some of the others in the room about particularly doing the echo component in the arrested trauma patient and not losing time when you get those brief moments to check?
So I'd say first thing is people probably underestimate themselves. All those images were our registrar images. So these are people who come to us to learn EFAST. And then yes, you don't want to get into the way of the interventions with your ultrasound. So in the video, I wasn't there while you guys were doing the thoracostomies. But then you also want to think, you want to get a good enough image to tell the team leader what is going on, whether you need to do a resuscitative thoracotomy. You're going to be able to look inside the patient. But at the same time, you give the ultrasound to the person who's best at it. But if you can't get a good enough image, you have to go back to basics and use your clinical knowledge and use the patient in front of you, because the ultrasound is an adjunct, it's a privilege, and if it doesn't work, let it go.
Yeah, I think it's really important to not get bogged down with everyone in the room staring at the screen and not have those other critical interventions not happening because someone's doing an ultrasound. Great, look, there's a few more. We've only got a couple of minutes. I'll try and fire through a few rapid fire questions. Anyone feel free to jump in. There's a question about doing bilateral finger thoracostomies before confirming pneumothorax in the arrested or arresting patient. Thoughts?
Yes.
Yes, why? Just for the benefit of people at home listening. Yeah.
It's a likely cause for the patient's arrest, and delaying to get an X-ray, sometimes even delaying to get an ultrasound, might not be beneficial for the patient. So I think decompressing in a peri-arrest, arrested patient is the way to go.
Yeah, great. So it sort of removes it from the list of potential problems, doesn't it? Great. Scott, you might be able to jump in on this one, or anyone else. Calcium chloride versus calcium gluconate in trauma, and why? And do you wait for a calcium level before administering if you're giving a massive transfusion?
This is quite controversial, this question. With a lot of us all on the panel have had thoughts about this, so thank you for giving me the mic. So essentially at the Royal Melbourne we only stock calcium gluconate, and so I suppose the important thing if you're thinking about or considering calcium from the perspective of mass transfusion is it's just important that we think about giving it for all of the reasons that we talked about in the talk before, and also just making sure that it doesn't always necessarily have to be at a fixed point within the transfusion. It can be at any point. So I think we mentioned, do you wait for a gas? I think a lot of the time as well, we have to consider whether there's been blood given pre-hospital as well, and keeping in the back of our minds where that sits in the algorithm. In terms of chloride versus gluconate, if you were to give gluconate, you have to give substantially more vials. But I know at the Royal Melbourne, we have talked a lot about this in terms of the cardioprotective components of giving calcium gluconate over calcium chloride. Do you guys have anything to add? I think it's more important just to consider calcium rather than getting hung up on what type you're giving.
Yeah, and I think it's important, like we were talking about, prepare your guideline, involve your haematology service, put it in there so people know and think about it, as Mark said, beforehand. Don't try and figure it out on the day. Great. All right, another question about when giving the MET-PAC or the massive transfusion, red cells or other products like FFP or cryo first?
Again, I think it's, as we said before, it's important to consider what they've had pre-hospital as well. So if there's been blood given pre-hospital, remember, ideally, in a perfect world, we want to replace whole blood. And we know that we don't have the capacity to do that with the MET-PAC, and we just want to aim for that 1-to-1 transfusion ratio. So I think, we could argue about it all the time, but it depends on individual patients, what they've had pre-hospital, and trying to maintain that transfusion ratio.
Yeah, great. Another quick question. Preparation for blunt versus penetrating trauma arrest. Emma and Amali, maybe, do you guys do anything different, set anything up differently, mentally prepare differently, think about other problems?
I guess, I talked about the standardised way that we approach the patient. Certainly with blunt trauma, you do need to remember to close the pelvis, so you have the pelvic binder ready and a tourniquet because there might be peripheral bleeding. Certainly in penetrating trauma, we'd have the thoracotomy tray, but it's fine to have it out, particularly if you're looking at a traumatic arrest. So someone peri-arrest, someone very unstable, that will be a time that I would bring it out as standard. And that's where training comes in. You do it every time and it just becomes routine.
Yeah, great. I think I've got one more minute. We'll throw it in. This is a tricky question. Control of junctional bleeding. So in the really hemorrhaging patient, we talk about how important it is and how a couple of surgeons sitting here in the audience will be itching to put their hands up. Kate, thoughts from the ED perspective? Makes me nervous.
It makes me nervous. I've been involved in a number of cases of junctional trauma and...
Should we just clarify for people watching online, by junctional we mean where the limbs join the body, so the groin and the axilla, classically difficult places to control bleeding.
Difficult to compress, and it's often more extensive than what you're seeing, and really it's, in my limited opinion, and I'd love to hear from the surgeons, trying to get the patient to theatre alive. So thinking about what interventions you can do, perhaps stopping not doing all the interventions, focus on vascular access, give blood, thinking about whether or not they need intubating now or just getting them straight to theatre.
Yeah, and I think one thing we haven't really touched on here is the OPSTAT process we also have at RMH, which is that just ejector seat push button, get the patient to theatre now, as long as everyone else is prepped and ready and on board and ready to go. But again, that's where having guidelines and practice and things comes in handy. All right, I think we'll wrap up the panel there. Thanks, everyone.
Fantastic insights and magnificently chaired, Andy. You've stayed on time. That's great. We've got a second panel now. We're really trying to get as much as we can. Can we welcome the second panellist down? We're going to get joining us Kate Martin and Rosha Kiran, who are two of our trauma surgeons here at the Royal Melbourne Hospital, are coming because it is a team sport and ED has a very small part of the team, really. We're there for the reception, but without these guys, there's nowhere for the patient to go. So Rose and Kate are joining us. Andy's on the panel. I'm going to go and sit on the panel. Dave Camilleri is kindly going to host, and we're just going to try and attack some of the issues around the big picture decision making.
All right, so ethics and decision making. I'm going to start off with Rose and Kate with a surgical question more than anything. Let's talk resuscitative thoracotomy. Is it only for the trauma centres? First question. It's a three-part question, two-part. And how to decide whether to embark on that outside the trauma centres?
Thank you for the question. So thanks everyone for having us along. Is it only for the trauma centres? No. I think we all appreciate that trauma can happen anywhere. The major trauma centres are only one part of our trauma system here in Victoria, and likewise in other parts of the country where it's a made-for-purpose system. So certainly, I know from a surgical point of view and also from an emergency point of view, we train people to manage trauma in as consistent way as is absolutely possible, given the resources you have available to you at the time. So no, it is not just for the major trauma centres. You don't really have much time to transfer someone to a major trauma centre if they're tamponading, and certainly not if they've lost output. So I think with the right personnel, the right training, we can do it outside the major trauma centres.
I don't have much to add to that.
Any different perspective from the ED physicians?
Oh, yeah, sure. I guess I've worked up in the Northern Territory a fair bit where resources are a bit more scarce and travel times are longer and that sort of thing. I think just adding to what Kate said, I think there is this fixation on the moment of the resuscitative thoracotomy, and I often teach that people see that as the end of your problems, and it's not. It's actually the beginning of a whole bunch of new problems that if you haven't thought past that moment, and hooray, I've cracked the chest and released the tamponade and you drop the mic and walk off, there's so much more that happens after that, and you need to have really planned and prepared and trained and practiced. Involve your surgical colleagues about what now, talk to your retrieval services if you're somewhere smaller about how you're going to get this person from a non-major centre to the major centre, because they need to go there. And what are you going to do about the bleeding when the heart starts again? How are you going to anaesthetise this person? How are you going to dress the chest wound? How are you going to fly them, transport them, exposing the patient to cold? All those things. It's a really complex process afterwards. So I think if you're going to do it, you need to sort of factor all of that in as well.
I'd second a lot of that. I started my consultant career working in a regional hospital a couple hundred kilometres from here. I'm sure there's some Bendigo people here. There's been very successful trauma thoracotomies either in the ED or in the operating theatre, rapidly transferred to the operating theatre from the ED in Bendigo, that have then made it down to here or to the Alfred. But that's happened because of a lot of effort gone into at those sites between the trauma surgeons, the anaesthetists, the ED people and our retrieval service to plan it out and to be sure of how it's all going to proceed. You're really obligated to make those plans. And I say that because even in Victoria, which is one of the most concentrated trauma systems in the world, we still can't get better than 2/3 of major trauma patients having their first hospital contact at a major trauma service. 1/3 will still land somewhere else, and they'll be spread out around all the other somewhere else's. Small numbers of them, but they make a big impact when they're there, and you can make a big impact to them if you put in a bit of planning.
Can I say one thing? So just Kate and Dave and I and others have talked about this. It's probably more important to focus on what happens before the thoracotomy and really work on your trauma arrest process, because if you get a lot of that right, you might actually avoid it in a lot of circumstances. And harping onto what you mentioned in your talk, Dave, as well, about it's actually okay to not proceed with things that you aren't trained or credentialed or set up to do, and not feel bad about that, that it's actually okay to call an arrest if you've done all those interventions. And the patient might have tamponade, you may have tried, say, a needle thoracocentesis or something, but if you're not trained and set up to do the resuscitative thoracotomy and the patient is deceased at the end of it, it's actually okay to call that. And that's an ethical conundrum as well. But again, it helps to have crossed that bridge mentally before the person's sitting in front of you.
Yeah. Thank you. So, I'm going to switch this one to Mark and Andy now. You guys are team leading. You're in the middle of a traumatic cardiac arrest scenario. It's an 18-year-old patient. You've treated all the reversible causes for this patient. When do you stop?
I'd hopefully have Kate or Rose or both of them standing next to me and we make a group decision.
As well,
I think I wouldn't make that unilaterally.
Yeah, I mean, I agree that in the video, what we showed was really a process of getting through all those immediate life-saving procedures, reversing the reversible causes, and really giving a circulation time to get your blood products around, get some blood to the coronaries, perhaps with some adrenaline, and give the person a chance to either start again or not. But that's only part of what you're doing. Another part of what you're doing is getting Kate and I, or Rose and I, a chance to talk quietly and say, what do you think about this? I think we're done. We're not going to get far because we probably know it already. And it's also a chance for us to get all those diverse people on the team on the same page, because we've all come together, haven't we, from several different departments, at several different levels of people, and many of us won't work together every single day. And that's in a place like ours with a high volume. Where if you're in a smaller volume place, you might know each other socially in a smaller place, but you might not know each other over a patient that well, unless you're doing a lot of these multidisciplinary team things. Any good things to add?
Having, unfortunately, being involved in traumatic cardiac arrests where the patient hasn't survived, I think it's really important to acknowledge, as you said, the members of the team who've been involved in an incredibly stressful situation and actually seek out their opinion, their thoughts. And so when the team leader decides that it's going to stop, I think it's really important to acknowledge the hard work that's done by every member of the team. And the cases that I have been involved, we've actually gone around and I've asked everybody, are you not that are you happy, but, can you think of anything else we could do? Do you have any objections? And I think that is really important. You don't want anyone walking away from the scene with a question mark of what if. And also this extends to the pre-hospital staff, the paramedics, because there is such a wonderful work before the patient arrives. And there are times they bring the patient to us alive, and then to see the outcome in the hospital, I think it's important for them to be involved in the decision making as well. Absolutely.
Yeah. Can't stop us talking now. We've got the chance.
I'm happy with that. Keep going.
The one other thing I'd add, and it just came to my mind as we're talking there, is that this is not a time to be proud and say, look, I'm supposed to be the team leader here. I'm calling the shots. At this stage of the process, you may well find as the team leader that you are run out of juice a little bit. You've gone through all these things. Your serotonin, adrenaline, and dopamine have all maxed out, and you've really got not much left. And you may not be. You might be great at giving orders and going through an algorithm, but you might not be the one who's got the greatest skill in the touchy-feely skills of going around the team, making sure everyone's on board. Or maybe you just don't have that in you at that moment. One of the nice things about the way we do it here with the surgeon and the emergency physician side by side is that although we have a clear role, the surgeon's here for making surgical decisions and the emergency physician's going to be the conductor of the orchestra or whatever, so we're not stepping on each other's toes, but we've got that resource, that extra person, and so we can lean on each other when you get to this really difficult part at the end. And I think it's just really important at any stage of the resuscitation to make use of everyone in the room, especially the other expert when you've got a multidisciplinary thing like this.
And just one other little thing, in contrast to a lot of our medical arrests, which I think is really important to differentiate this from, a lot of these patients are young adults who were fine an hour ago, driving home from work, or something they carry no comorbidities a lot of the time, or very few. It's a very sudden, shocking event. You've got this young person who was walking around talking, now deceased in front of you, and everyone wants to do absolutely everything for that person, and that's where I think that the emotion and the ethics come into it about how far do we go, how long do we keep going. But again, coming back to practice, guidelines, preparation, having talked about these things with your team, so you have clear stop points as well to say, look, I think we've reached the end of the algorithm here. And exactly as Rose said, I think it's really important to go around the room. Have we missed anything? Again, I'm maxed out. I may be task focused or too fixated on one part of the resus. I might have missed something really obvious. It's great to have that second set of eyes just to bounce it off before you make a big decision on a young patient.
We're out of time, I believe. We've got time? Oh. All right, I'll ask you another one then. We've been talking about traumatic arrest for about an hour and a half now, but is it even worth it? Can you tell me about the outcomes maybe, and are they good enough to justify all this work that we've been talking about?
I can give you a biased opinion.
Yeah.
I had I actually performed an ED thoracotomy as a trauma fellow, and it was in blunt trauma in a 26-year-old man who survived. And so having spoken to him afterwards and met his family, I can definitely say it's worth it when it's done for the right indications. It was tamponade confirmed on EFAST, and it happened. He was just incredibly lucky to be in the right place at the right time with appropriately trained staff and an institution that had the means to support him. And so anytime someone asks these questions, I remember this case and I say, yes, it's absolutely worth it. So that's my...
One of the features of trauma, and I will put my surgical hat on here as opposed to other forms of surgery, is that we make decisions based on probabilities. Much of what we do not have a definite answer for. When we do elective surgery, we know the patient's got bowel cancer or we know they've got gallstones. The patient's having an AMR. If you're sending someone to the cath lab, you know you've got confirmation they're having an AMR, or it's an asthma event and you're intubating them. So one of the first things we teach our surgeons is to become comfortable with making decisions based on probability. And if the patient has a knife in the heart, in the box, I should say, and they were talking and now they're not, and even if you can't get good views, you might have some subcutaneous emphysema, chances are they've probably got. Likewise, that patient who has lost output in front of you relatively, in a short space of time, there is a chance. And I think, it's like in this, I think it's the cycling world where they talk about the 1% and it can win you gold medals. Well, I think we're very fortunate to live in a very mature trauma system, and it is these 1%, 2% that will make a difference to morbidity as well as mortality. And so it's our outcomes as well.
Yep.
I think we have some data from Melbourne from an audit here where I think we found about a 15% survival rate from cardiac arrest in trauma, which is pretty reasonable when you compare it to medical cardiac arrests. Some overseas data has found probably about 50% of survivors have good survival, have good functional survival, which again is a pretty good result, especially when you're talking about a population who start, they've got a lot to live for yet and a lot of life left to live. So I think that's really worth considering. You'll see different numbers from different studies because it's all about the denominator and it's all about your patient selection. But if you're, I would say on the patient selection thing, I think the difficulty is that if you put a lot of time in selecting your patients, you won't have any patients because all these decisions need to be made very quickly, and this cohort of people, as Kate pointed out. And the thing to remember is that all these interventions up to thoracotomy, all of the others, all of those routine ones that you're really going to be trained to do, they're the ones you do for peri-arrest, just as the same as they are the ones that you do for the arrested patient. And what you're really doing when that person comes in, they've just started CPR or started bagging them as they roll in the ambulance bay, you're hoping they're a peri-arrest patient. You're hoping they've still got a little flicker of output and they just got bored of talking to the ambo, and what you're going to do is you're going to start doing all these procedures and get them back before their heart is stopped. Because what we want to do is we want to get them back while there's still that cardiac activity and while their brainstem is likewise still intact. So you've got to launch it. You've got to be prepared to launch into it early. Now there are times when you don't, and there are guidelines around for when you needn't start. The trouble with those is that there's a lot of case series of survivors that most of them wouldn't have made the grade according to the guidelines of when not to start. And so that's just worth bearing in mind. And the biggest problem is time and downtime. And downtime is such a vague term in the heat of the moment. So if there's any doubt, I think you start. If you've got a very clear story of someone who's arrested long before they arrived at your institution and there's been a heroic effort en route with a really prolonged period of CPR without the genuine life-saving interventions, that's perhaps the time when you might choose not to, or when you know something about the patient beforehand that might set them up as not a good candidate. But I think it's reasonable to start. You can always stop once you've started, and it's harder to start once you've stopped.
To close up, I think you guys really made me think of a phrase I heard repeatedly at a conference this year overseas, and that was, it takes a system to save a life. And I think we keep talking about how we work together and we involve all these other specialties sometimes to help us in these cases. But I think it goes even further to our pre-hospital colleagues, and potentially if you're working in a regional centre, your colleagues who are receiving the patient after you have seen them. So I think we need to embrace that we're part of a bigger thing, and we need to involve these other systems and make sure we have a process that we can all follow, but also a process, I guess, towards the end about how we take decisions and how we decide when to actually call it. Either way, whether we have ROSC or whether we don't. Thank you all. Thank you.
All right, more of me talking. We're up to next. That's the next panel. Next panel. I've got to turn the page. Lauren DeLuca, are you in the room? Lauren DeLuca, one of our obstetricians, well, not our obstetricians, one of next door's obstetricians. We're lucky here at the Royal Melbourne that we're part of a precinct. The Royal Women's Hospital is right next door. You can walk straight past our cafe and you find yourself in the Royal Women's Hospital. Lauren is the head of the birthing suite, I think, or birthing service at the Royal Women's, but has a interest in human factors, which makes her particularly good for what we're talking about here. You're going to talk about the big one, resuscitative hysterotomy.
Who's controlling the slides? Am I?
I was hogging the flicker.
There we go. Which one is it? Big one? All right, that's easy. All right, thank you for that kind introduction, and thank you for the opportunity to talk to you tonight. So I'm here to present on resuscitative hysterotomy. And hopefully you won't have to deal with this too often. I just do want to acknowledge, though, that if you have been involved with the cardiac arrest of a pregnant patient, they're not easy, and particularly if there is a poor outcome. So just to make you all aware that this topic may be triggering, and obviously if you have any distress related to this talk, please make sure that you speak to your colleagues or contact your EAP. This is probably how all of us feel if we have a cardiac arrest in a pregnant patient. And obstetricians are no different. This is incredibly rare. We don't see it very often, and hopefully you won't either. So the incident really is around 1 in 20,000 to 1 in 50,000. Obviously, we would see it a little bit more frequently here, being co-located with Royal Melbourne and receiving traumas. But if you're regional or in outer metro, you're unlikely to see this in your career, which is good. Maternal mortality in Australia is, again, very, very low. And if you compare it to the USA, we have a mortality ratio of 4.8 per 100,000, and compare that to the US, which is 17, which is quite a stark difference. And if we look at our own statistics here in Australia, this is the most recent data which is available through the Mother and Babies report, and this is from 2019. And this gave a rate of 6 in 100,000 maternal deaths. Majority of them are still directly related to pregnancy, but only just. So about 40% are actually indirectly related. And still our major causes of maternal deaths is sepsis and thromboembolism, and that really hasn't shifted with time. I only have 10 minutes, so we're not going to go through physiological changes in pregnancy. There are lots, so refer to your textbooks for that one. But a couple of things just to remember, and this is sort of really guides our principles of why we do a resuscitative hysterotomy. But if we think about compression of the IVC, the impedance of venous return, increased oxygen consumption, making cardiac life support much more difficult to achieve. And also the fetus has limited reserve if a woman loses their cardiac output. So just a bit of a refresher on the gravid uterus. If you get a patient that presents, I'm not going to expect you to get a tape measure out and try and work out their gestation. But equally, you may not know their gestation, and all you may be able to feel is a bump on their abdomen. The only thing I really want you to take from this slide is the umbilicus is the most important part. So if you feel a fundus at the umbilicus, chances are they're around 20 weeks pregnant. And that's sort of our cutoff for where we think a resuscitative hysterotomy may be useful. Now, of course, if a woman has twins or triplets or she's got a very large baby in there, the gestation may be earlier, but it actually doesn't matter, okay? So gravid uterus at the umbilicus, that's your starting point for thinking about a resuscitative hysterotomy. I think this is a really important take-home message. We manage the mum and we think about the baby second. And I think one of the first things we think about, particularly in a woman that might be in the third trimester, is, oh, we've got to check what's happening with the baby. We need to check a fetal heart. Where we need to concentrate on taking care of mum, and then we will naturally then help to save that fetus. But mum always comes first. So this is a bit of an overview, and we'll go through a bit more of the practicalities practicalities in the next few slides. But it's really important to know that a resuscitative hysterotomy is named or termed that because it's part of your advanced cardiac life support. It's a resuscitative measure. And as we talked about before, what it does is when you've got a gravid uterus that's compressing those great vessels, by doing a resuscitative hysterotomy, you'll relieve that aortocaval compression, you'll increase your ability to ventilate, and you're reducing your oxygen demand as well. So, as we mentioned, 20 weeks is your cutoff. That's when we really think that it will make a difference. Obviously, you continue with your ABCDs as you go. It's important if you've got a pregnant woman that when you are doing life support, cardiac life support, that you need to make sure they're either placed in their left lateral tilt position or that someone is manually displacing the uterus. And the reason is, if you can see that image just on the side, when a woman is lying supine with a gravid uterus, it compresses those great vessels, so you're going to reduce your cardiac output even more. So by putting them on their side or relieving that displacing that uterus, you'll help relieve some of that pressure. If you're going to do this procedure, you don't move the patient. We know that the outcomes are better, and I'll show you a little bit of a series around outcome predictors, but leave the patient where they are. Ideally, you want to start thinking about this at the 4-minute mark. So if you haven't got return of circulation after 4 minutes of doing cardiac resus, start thinking about it, get your equipment ready. The incision doesn't actually matter. We'll go through that in a bit more detail later. And really, why are we doing it? Because we want to maximise maternal survival. And if we get a live fetus as well, then that's a bonus. So these are just a couple of series that have been looked at. So the first one really looked at survival. And as you can see, maternal survival is still not that great, even with doing a resuscitative hysterotomy, so 25%, but the actual fetal survival is quite good. And obviously if you're more advanced gestation, then there's more chance of the fetus surviving. Beckett's paper looked at maternal outcome predictors, and I think this is really important because this just highlights why we do and don't do a few things. So we know that if they arrest in hospital, obviously much better chance of survival. If the hysterotomy is performed at the site of the arrest, then again, much better survival, 72% versus 32%. And that's because we're not wasting time by transferring, because we're looking at 4 minutes, it's not long. But also, you can continue your advanced life support instead of sort of starting and stopping as you transfer. Time to delivery, so better outcomes if it was, I think it was the median, or the average was 7 minutes to hysterotomy versus 16 minutes. And women that had a high BMI were at greater risk of not surviving, which one would expect. So, if you've got a cardiac arrest in a pregnant woman, obviously call for help. So if you're in a tertiary centre that's co-located with an obstetric hospital, you're in luck, because we are right next door, and we've got some good processes that our Gandelsim team have actually established to get us across. If you're regional or in an outer metro and you don't have obstetric support, think about who might be able to assist you. You may want some surgical assistance, if you've never done any surgery before, I think that's perfectly reasonable, but also think about the baby. And you may want to give Piper a call, which is the retrieval service for paediatrics and neonates, and get them on their way as well. Obviously, if you don't know the gestation, it's hard to know if you need Piper or not. I think, you are on the side of caution, call them and have the conversation over the phone, and they can help you decide whether they'll attend. There are some nice resuscitative hysterotomy sets out there that you can purchase and have in your centres, and there are ones dotted around the Royal Melbourne and around the women's as well. But really, you actually don't need very much. You need some gloves, a scalpel, and really the rest can come at a later stage. So gloves, scalpel, packs are handy. You won't need them immediately because there's no circulation, but if you do get return of circulation, you will find that they will bleed, so it's good to have them handy. But also, when we transfer to theatre post, obviously we want to pack the abdomen while we're waiting. Clamps to clamp the cord. If you don't have baby clamps that look like that, you can just use any curved arteries or things like that work. We also suggest, if you've got a very preterm baby, wrapping a baby in plastic. So if you've got a bag of some sort, then that just helps preserve their temperature and helps preserve heat, and they do much better. Again, you can be creative and find whatever you've got in your department. Kidney dish is helpful to deliver the placenta, to have something to put the placenta in, and an indwelling catheter is helpful to drain the bladder, but I certainly wouldn't recommend putting that in before you do your resuscitative hysterotomy, because again, you're going to waste time. In the end, it's a very crude term, but it's a bit of a slash and grab. You go through structures, get the baby out, and then deal with the complications later. And if you do happen to go through a full bladder, a bladder can be repaired. That's the least of the problems here. So some practicalities. How do we do it? First thing is skin incision. So opening the abdomen, there is no right way. Me as an obstetrician, we were just having this conversation when I was in birth center just a couple of minutes ago. I would do a fan and steel or transverse lower skin incision because that's how I am most comfortable and I'd get in the quickest. But a midline is perfectly acceptable as well. The benefits of having a midline is obviously if they've got other surgical issues, then the surgeons can take over and explore the abdomen, so there is some benefit there. Incision on the uterus, again, either a lower transverse or a midline. The lower segment of the uterus doesn't form until third trimester. And I sort of wouldn't expect any of you to know whether there's a lower segment or not. So really, up or down, it doesn't matter, whatever you're going to get the quickest to get the baby out. Delivering the fetus with fundal pressure, so often having someone on the fundus just to press down to help you deliver. If they're very preterm, they're often going to be breech. Hopefully, if they're cephalic, it'll just come. But otherwise, you can go in to grab limbs and things to get the baby out. Clamp the cord twice, cut between the cord, and that separates bub from mum, and then deliver the placenta. And the placenta can just be delivered either, it'll deliver spontaneously, or you can deliver it manually and again, just scoop it out and check that the inside is free of any leftover placenta. We normally would massage the uterus just to encourage contractions and then really packing the uterus until you can suitably get to theatre. And obviously be aware that the uterus will bleed and the incision will bleed if you do get return circulation. So I guess just a couple of reminders. Again, don't check the fetal condition. The last thing you need in this situation is to know that a fetal heart is sitting on 60. It creates more anxiety and there's actually nothing that you can do about it anyway. In terms of prep, just be aware about using alcohol in the setting of also having a defibrillator, because again, you're going to be continuing with your advanced life support at the same time. Again, if you've got something handy, throw some betadine on, but equally, it's the least of the concern here. You don't want to waste time waiting for prep. And after you have finished the hysterotomy, so again, continue your advanced life support, packing the abdomen, and then transfer to theatre once you get a chance. So in summary, manage the mum and worry about the fetus later. Big take-home message. Gather your team, think about who you might need early on and get them in the room. You can also call Piper to speak to an obstetrician over the phone, and sometimes they can actually guide you through the procedure as well, so they're quite a handy resource. Think about paediatric, but also think about what codes you could call in your service. So if there's a paediatric code blue, that might get a paediatrician there, that might get anaesthetics, people that might be able to help resuscitate a baby, that might be useful. Again, 4 minutes is the crucial time. So at that 4 minute mark, if you're not getting anywhere with your resuscitation, start thinking about it. Don't move the patient. Remember your left lateral tilt or your uterine displacement, and really choose the best incision that you feel most comfortable with. But as I said, there's no right or wrong here at all. So thank you, and just a couple of acknowledgements. Some of these slides were adapted from Rebecca Zabo, who is our lead for the Gandel Sim service, which some of you will know very well, and also Anthony Woodward, who was my predecessor. And thank you.
That's great. Fabulous. Thank you so much, Lauren, for doing that. And so that's the big message. Take care of mum first, and get that right, and then everything else should fall into place if it's going to. All right, we've done a lot tonight. You've prepared the team. You've got vascular access. You've stopped major hemorrhage, decompressed the chest. We've checked the pump. We've given blood, done a thoracotomy and a hysterotomy. It's been a big deal for the team. Nicola Walsham is now here, Deputy Director of ED and very experienced emergency physician at Royal Melbourne, and she just attracts trouble in the ED. I think she's more thoracotomies than any emergency physician at the Royal Melbourne. She's going to talk about what you do afterwards, which is how you put your team back together, a critical incident debrief. Thanks, Nicola.
Thanks very much, Mark. I am going to start with a little story. A couple of years ago on a lovely grand final day, and there were quite a few of you in the room who were actually there, we got a bat phone call about a highly pregnant woman, about 30 weeks pregnant, who had been pushed out of a car by her partner, out of a moving vehicle by her partner, and was coming in traumatic cardiac arrest. About 2 minutes later, while we were preparing that team, we got another phone call to say that there was a 16-year-old boy who'd interrupted a home invasion and had been stabbed in his thigh and was shocked. And they both came into emergency. And the woman had a resuscitative hysterotomy in ED. And initially, she died, and initially the baby survived, but went on to die a week later. The 16-year-old boy who was in the cubicle next door had been stabbed in the femoral artery, and he bled to death. And his family were a Maori family, and the screaming and the wailing was distressing beyond distressing. And everyone clearly was traumatised by those two events, particularly because they happened back to back. So that's my first story. And obviously that's a critical incident. But in actual fact, a critical incident can be anything. It can be any event that's significant enough to overwhelm a person's normal coping strategies and cause them psychological distress. And it's much more defined by the impact on the person than the event itself. But for most of us, what is a sort of average critical incident? Well, pretty much any trauma-related death, particularly where there are complex psychosocial contributors like domestic violence or non-accidental injury. It also includes patients where there's been a medical error, or where there's been teen conflict, or we've performed a rare procedure like a hysterotomy or a front of neck access. And it's important to note that it's a highly personal response. Some people exposed to a critical incident will have little or no psychological distress, and others will be completely overwhelmed and be unable to work. And there's a lot of reasons for that. It can depend on the stage of your career, your underlying mental health issues, your psychosocial supports, what happened within there, your perceived sort of performance within the resuscitation itself. And fortunately, most of us recover. But about 15 to 25% of people who are exposed to critical incidents will go on to develop more serious problems, including PTSD and burnout. And for all of us who work in emergency services, we are repeatedly exposed to critical incidents over time. So, it is incredibly important to work out ways to mitigate the impact of critical incidents on our staff. And what sort of things do we see? Well, acute stress disorder is the most common response that we see after critical incidents. And I just want to point out that these are very normal reactions to very abnormal events. So, one of the ways that we can mitigate the impact of critical incidents on our staff is to debrief. And I can almost hear people in the room going, isn't that been associated with harm? And it's really important to define what is a debrief. A critical incident stress debrief is a particular form of mandatory group debriefing, which encourages individuals to recount in detail the traumatic event and their emotional responses in detail. And Cochrane collaboration in 2002 found that this was actually associated with increased PTSD. But for most of us, a debrief is the group meeting where we come together after a critical incident to discuss what happened and for the provision of psychological first aid. So psychological first aid is an evidence-informed approach. It reduces initial distress and addresses people's basic needs and concerns by providing them emotional comfort and support, practical information and advice, and connecting them with their existing support services, as well as providing links to professional services. It's not psychological debriefing. It's not counselling. You don't have to be a psychologist or a counsellor to deliver it. And importantly, it's not been shown to be associated with harm. So what does a hot debrief look like? There's a hot debrief which occurs immediately after a critical incident, and there's a cold debrief which occurs 24 to 72 hours later. Well, a hot debrief, it's short. It's 5 to 10 minutes. And a lot of you in the room say to me, can't do it in 5 to 10 minutes, but you actually can. If you follow a standardised process and a format, you can achieve this in 5 to 10 minutes. And that's important because there's multiple competing clinical priorities which make everybody, the surgeons and the anaesthetists, they go up to the trauma op stat, they can't come to an immediate debrief. And in ED, all of the resources have been funnelled into looking after that one patient who's dying. You turn around, there's 40 others waiting. Nonetheless, you can do it. It should occur immediately afterwards, but we want everyone to come, so you might need to wait a couple of hours until the surgeons and the anaesthetists have finished in theatre. It should be routine after every critical incident, and anyone should be allowed to initiate it. If a critical incident is defined by the impact it has on a person and it's individual, then the person in the room who's impacted by it, even if nobody else is, should be allowed to call a critical incident debrief. Importantly, it shouldn't happen in the room where the resuscitation occurred. So we hold ours in our handover room, which is a sort of a safe space away from the resuscitation areas. And anyone who's directly involved should be invited to attend. And this is across all craft groups. We'll invite ambulance, we'll invite medical, nursing, clerical, cleaners. We'll invite radiographers, and we'll also invite the women's obstetricians and the neonatologists when we can. And the most important thing about it is that it's voluntary. The issue with critical incident stress debriefing was that it was mandatory. This is voluntary and everyone should be invited to attend, but it's not compulsory. It should be led by trained facilitators, and you can't be the ones who are involved in the resuscitation. If you are the resuscitation team leader, you're so triggered yourself that you can't adequately lead a debrief. And ideally you should have 2 trained facilitators, one who leads the debrief and one who's reading the room. So the person I'm most worried about in a debrief is the person who's sitting in the corner, looking at their feet, not saying anything. And that's the person I'm going to follow up with after I leave the debrief and check in on them and see how they are. So in conjunction with the hospital wellbeing team, in ED we created our own debrief model, which is called the OK Stop model, which is based on other validated debrief tools internationally and nationally. But it takes into account the Melbourne Health values as well. So starting with OK, you gather your team in the handover room and you check in with your team. Are you all OK? And I think it's important to own the incident. Acknowledge that, this incident wasn't normal, it was potentially distressing for everybody involved, and whatever you're experiencing is normal and understandable. Next, you set the scene. You've got to set some ground rules for the debrief. We're going to have a 5 to 10 minute debrief, team debrief. The purpose is for staff wellbeing. It is not a performance review and it's not a blaming session. Everyone's voice and opinion matters, but please lead with kindness and respect each other. Your participation is welcomed, but not at all compulsory. As a couple of people have spoken about, no one comes to work to do a bad job. Everyone wants a good outcome for the patient, and it's very distressing when you don't get a good outcome. But it's important to acknowledge that everybody tried their best and nobody wanted the outcome that occurred. Summarising the case is the facilitator's big next job. And this is actually critically important to make sure that everyone understands what happened so they can help make sense of it. If you're really busy in a recess and you're very task focused on doing one thing, you might actually not know what's happening over on the other side of the room. And equally, if you're a non-clinical person, you may not understand what's transpired. So by summarising the event, that helps with the collective understanding of what's happened and helps people make sense of the event. Highlighting the things that went well. The facilitator can start with this, and areas that can be considered, you can have communication, team leadership, it can be the procedure that was done well, it can be the time to get to CT. And I think it's important here to open this up to the room and ask the team what went well. And I often like to ask the micro team, so airway team, tell me what happened that went well, because by focusing on a team's performance, you're avoiding talking about somebody's individual performance, which might make them triggered and more upset. And I should say that in summarising the case, it's also useful to ask everybody in the room, what happened there, tell me a bit more about the event, because by talking about it, if they feel comfortable to do it, that helps them make sense of what's happened to them. Then there's the difficult bit, the opportunities to learn. At this point, the facilitator needs to open it up to the group to talk about if there were any things that could have been improved on. And I think this is the most important part of debriefing, because it's usually the human factors issues that people are so triggered and heightened about in many ways. And it's important to allow a safe space to be able to allow people to speak openly and safely. However, you do need a very skilled facilitator to be able to contain a group's emotions, and if they're starting to be judgmental, blaming, commentary, to shut things down very quickly. I think you need to acknowledge that there were issues, but agree with the group to park them for later for operational review. And lastly, the P's. People need to be offered the opportunity to go have a break or tap out of the role that they're in, or else some of them may even need to be able to go home, told to go home or offered the opportunity to go home. Should provide some information about self-care tips, make sure you get a good night's sleep, make sure you have something to eat when you go home, do you need a taxi to get home, those sorts of things, as well as support avenues, peer support, the hospital wellbeing team, EAP, contact with a line manager. You do need to ponder the need for a cold debrief. As I said, the hot debrief is immediately afterwards. The cold debrief is run by the organisation's wellbeing team 12 to 72 hours later when sort of emotions have heightened down. Now, in my experience, it's not often needed. Hot debrief is usually enough, but there are certain cases, like the first example I used, when a cold debrief was clearly necessary for all. Points to action. The main thing is to sort of recognise the staff in the room who are actually appear to be impacted, and make sure you follow up on those people individually after the event. And you also might have identified issues, quality improvement or human factors issues, which need follow-up at operational level, RiskMan, M&M, IDCR, etc. And lastly, you need to put it in writing. And we have a QR code which links to a form which says how many people attended the debrief, not their names, and any issues or people that need to be followed up. So look, there are a lot of barriers to running routine debriefs after critical incidents, and you all know them. Team dispersal due to competing clinical priorities, a lack of trained facilitators. Usually the people who are most impacted by it actually don't attend the debrief. So it's important to know who was in the resuscitation room and whoever's leading the debrief to follow up with those people who didn't attend and check in with them if they're okay. And lastly, there is a cynicism amongst some people about the value of debriefing. But despite all of that, every time we run a debrief, there's an overwhelmingly positive response. People report reduced distress, they report increased job satisfaction, and they increased team cohesion. And that's not just the experience of the Royal Melbourne, that's an internationally recognised experience. So, we will continue to try and make debriefing a routine occurrence after every critical incident, and I'd encourage you to do the same.
Thanks, Nikki. That's one more example of major trauma care that it all depends on preparation. The investment that people in a role like mine and Nikki's and those around us put into the culture of the place every single day leading up to an episode like this is what creates a space where that can be carried out in a positive and constructive way. And I think you need to be investing in that all the time because, in order to keep it right and to keep trying to get it better, because it's never quite right, but to get it better and better so that people can speak safely about those things and get on and take care of the next patient and the next one. That's all we've got time for. We're 8:30. Thank you all very much for coming. We've done a lot. We've navigated some IT connectivity issues. We have gone through a lot of material. It'll be worth watching again. Thank you very much for coming. I don't think we've got anything else. There's a little bit of catering for those who are in the room, just in the room next door, so please enjoy that, and good night.